two classrooms over there. Albany, can you guys wave or send me some kind of acknowledgement if you can? Thank you. Okay, and then is that Savannah? Savannah, can you let me know if you guys can hear me? All right, and what about Augusta? All right, great. Okay, so Savannah, the camera that I can see is just pointed to the corner podium in the room. I don't know if you guys were interested in readjusting that or not, but.
She can't even see us.
Okay, welcome back. We've had a bit of a break. I just wanted to go over any housekeeping items or questions that you guys might have. It's been a while since we've met. So today we're going to have class. We'll have a lecture on pharmacogenomics in oncology. So now we're going to switch over to cancer, meaning that half of all pharmacogenomic examples revolve around oncology and cancer treatment and how we approach treating malignancy as far as somatic mutations and germline mutations, which we'll go over today. On Thursday, per your scheduled booklet, we will not meet as a class. So on your syllabus, when you see some date highlighted in pink, that means that's a recorded lecture. You guys have another program to go to, and so they usually reschedule me for Friday, which does not bode well for my schedule, and it's typically disruptive to the students as well, and therefore I just record class for that day. So please do not show up on Thursday expecting to have class. No need to let me know if there's an issue with coming to class on Thursday. And so this will be the only time that we'll meet as a group this week. I will record the lecture. I already have the slides posted for Thursday, and I'll record the lecture and put that up. Fair warning, it's going to be content dense. It's not going to be a fun lecture to listen to. I apologize for that. There's just certain important metabolic pharmacogenomics in cancer that you need to know and that you need to be aware of. And so it might not be the most fun thing to listen to. Fair warning. Are there any general questions before we get started? Yes?
For those of us that are doing the pharmacogenetic testing through Dr. Logan, and we've already sent out our sample, is it going to be too late for us to use that for this class?
No, hopefully not. We can talk a little bit more about that after class, but ideally we wanted to have that done earlier in the semester.
There's two swabs.
We can discuss that, but
you mess up one,
we want to be able to use that for this
She
class.
doesn't think you'll mess up, but just in case she had extras.
So yeah, if you're involved in that, see me afterwards so that we can make a plan for how we're going to approach that. Other general questions? All right, so then today let's get started talking about pharmacogenomics in oncology. There are certain considerations in oncology that we might not see when we're treating other malignancies or other diseases. We want to, of course, our overarching goal is to prescribe appropriate anti-cancer therapeutics to treat the disease, but it's not as simple as it sounds. We want to deliver more predictable responses to drug therapy, particularly chemotherapy. Chemotherapy is the most toxic drug arsenal that you have in a formulary. So we want to be very careful about how much we dose, to whom we dose, and that we're getting this right and this treatment's appropriate. Of course, we want to minimize adverse drug reactions. There's going to be side effects with this treatment, as with all treatments. The difference here is with oncology, you're allowed to use FDA-approved drugs that will almost kill a patient, right? They're very toxic. They can be life-threatening, and that's allowed because you're trying to rid them and rid their bodies of another life-threatening illness. And so again, we have to be very careful about how we dose them, when we dose them, and monitor and minimize any adverse drug reactions. We also use pharmacogenomics now to accelerate the drug discovery and drug development these days. Companies and cancer centers are very interested in using patient databases with genetic information. Meaning, if there is a hotspot in the genome, drug companies might be very interested in learning about that and coming up with a drug to target that. And then if they want a clinical trial, they may also be interested in which cancer center has this patient population or access to patients with this mutation. And so what would be best available for me to use this drug in a clinical trial? And so it goes both ways, for the drug companies and also for the patients. And the patients, if they've had their genome put into a database at a cancer center, they might be called up later on to ask, do you want to be a part of this clinical trial? We have a drug company that has made something for your specific mutation if you're interested. We also want to develop more cost-effective clinical trials with a better chance of success. In some ways, this is almost a misnomer when we start to talk about cost-effectiveness in oncology, because these drugs are just so incredibly expensive. But that's one of the reasons that they tout pharmacogenomics in oncology. And when we are prescribing appropriate anti-cancer therapeutics, we're not just thinking about getting rid of the tumor in the body. We also have to think about all the supportive medications that are going to be relevant to anti-cancer therapeutics. So for example, a lot of chemotherapy is going to make patients very sick. Chemotherapy-induced nausea and vomiting, CINV, is a common abbreviation when it comes to cancer treatment. So we have to treat gastrointestinal issues in the patient. We need to think about pain management for the patient, neuropathies that might be experienced, mental health. Not only is cancer depressing and debilitating, but some of these drugs affect the mind. We have to think about sleep for the patients, and we have to think about their risk of infections. We know we're going to be reducing the white blood cell count, and how is that going to impact our patients? So what I'm trying to communicate is everything you know about treating other issues could come into play in oncology when you're thinking about not just treating the tumor, but treating the whole patient and the experience from the drugs and the side effects, and just the overall experience of having a diagnosis with cancer. For pharmacogenomics, we want to know what's causing or what's driving the malignancy. There could be mutations, there are genetics involved in that question. There are two different ways to look at this. We can think about cancer as a spontaneous tumor formation, something that has been caused by a somatic mutation. We may also think about it as something that's been inherited from generation to generation that's causing the tumors. And in this case, we think about germline mutations. So let me describe this a little bit better as a visual. There's a difference between germline mutations and somatic mutations, and we have to think about both of these issues when it comes to treating a cancer patient. Okay, so on the right-hand side, I have an illustration from the internet describing germline mutations. So what you see here in red are cells that are affected by the mutation. So the red, the sperm cell, has the germline mutation in it, not the oocyte. It is passed down to the embryo because it's the germ cell, and the entire organism then carries that mutation. And so half of the gametes have carried that mutation that can get passed on from generation to generation. So this is something that can be inherited, and it's called germline because it's in the germ cells being sperm, oocytes, those involved in regeneration. Then we have somatic mutations. Somatic mutations, in this illustration, you can see the sperm and the oocyte, they're not red. They do not carry any type of mutation. But you see in the embryo, that little red spot, that's a somatic mutation. So that's something that wasn't inherited, but something that's evolved within the organism. It's not in the germ cells. And then as the organism develops, you see that red patched area, and then none of the gametes will carry the mutation. So when we think about this and its application to cancer, we have the patient, which will have possibly germline mutations. It's not necessarily going to apply to all your patients. And then there's the tumor, and the tumor may have somatic mutations, meaning we've got to think about what's going on with the patient, and then we also have to think about what's happening within the tumor, which is the actual problem that we're trying to treat in that individual. And there are a lot of different influences on treatment outcomes. So on the right side, we're looking at efficacy, and when it comes to efficacy, we have to think about the tumor sensitivity. And this is going to involve not only the germline genetics, but also the somatic genetics. When we think about the drug mechanism, the resistance mechanism, all of these can evolve completely separately in the tumor as a result of somatic mutations. And that's going to affect the drug efficacy and therefore the treatment outcome. On the other hand, when we think about toxicity, the mechanisms, the underlying disease, the toxicity resolution, and the patient sensitivity, these are more involved in the germline genetics. So again, we have to consider both when we're thinking about treating the tumor and the patient. Here are some examples of pharmacogenomic markers in the somatic mutations in the cancer. So the one that we're going to be talking about later on today is ABL. Breakpoint cluster Abelson tyrosine kinase. And this is a mutation, is actually caused by the Philadelphia chromosome, and I'll have a visual on that later in the slide. But if somebody does have that biomarker, then the drugs that are applicable are listed here. And so it started with imatinib, and now we have a lot more drugs for this. And so what that means is whatever the tumor is doing, we may have a specific drug target for the tumor. Other of those pharmacogenomic markers will sort of evolve and get to in other subsequent lectures in this section on oncology. Then we have the germline pharmacogenomic markers, and some of these you may be already familiar with. We've talked a little bit about CYP2D6. Now, granted, we haven't talked about it with tamoxifen, but we'll get to that next week. And so these are germline, and these are more affecting the outcome of efficacy as well as drug toxicity, versus when we look at the somatic markers, we're just looking at efficacy. We're just looking at what the tumor is doing versus how the body is going to react to that drug. And so here are some more somatic pharmacogenomic markers. So these are different proteins caused by genetic mutations at the DNA level. And so these proteins are then transcribed and they're aberrant in some way. Usually that means they're activated. That's not always the case, but just as a general rule, if there's a DNA mutation causing cancer, it's probably an activating mutation in an enzyme or a protein. And that's going to translate into, let's say, increased proliferation, increased survival, less apoptosis, more angiogenesis, something that's activating in something that might be fine in the developmental pathway, but is completely abnormal in an adult human and shouldn't be there. And so again, here are just some examples of those. And then whenever you see some writing next to this, so example EGFR, cetuximab and panitumumab are of course monoclonal antibodies to inhibit that receptor on the outside. Fatinib, erlotinib, gefitinib are small molecule inhibitors to inhibit the EGFR receptor on the inside of the cell. And this isn't a complete list, this is just to give you an idea of some of the things that we're going to talk about in subsequent lectures. Some of these you may already be familiar with as well. Now the first example, I'm going to give you two examples today. The first example that I'm going to give for a drug that's used in a cancer, but it's a non-malignant type of cancer, involves both inherited and somatic mutations. So both issues are at play here. And this doesn't show up in the estimated number of new cases or the estimated number of new deaths. What you have to go down to is where I have this yellow arrow at the very bottom of the figure legend, where it says, here the figure is the 10 leading cancer types for the estimated new cancer cases and deaths by sex, United States, 2018. Estimates are rounded to the nearest 10, and cases exclude basal cell and squamous cell skin cancers. Meaning, this graph does not have skin cancer on it. Could be for a number of reasons. My guess is that these types of skin cancer lack the malignancy and the aggressiveness that these other cancers listed here have. Because if we were to include these skin cancers, they would be much greater in number than all of these cancers put together on this list. And so what does that look like? Well, 1 in 5 Americans is going to develop skin cancer by the age of 70. In addition to that, when we think about the diagnoses of basal cell carcinoma just in the United States every year, we're over 4 million. When we think about squamous cell carcinoma, we're over 1 million in a year. So again, if we were to add these to the graph, it would look like millions and millions of people get cancer. And while that may be an accurate statement, again, it's the malignancy that's not really there in these types of skin cancers, which is probably why they're excluded from that overall graph. And so what you're looking at here is a typical example of basal cell, which are sort of the basement cells of the skin, a basal cell carcinoma, and a squamous cell carcinoma, squamous cells being the skin cells. And this is a slightly better illustration describing a squamous cell that develops in the cells that form the skin surface. And it's most likely to appear in sun-exposed areas, meaning that ultraviolet radiation is really the driving reason why people get these types of cancer. Although, of course, there can be inherited predispositions. And then we have basal cell, which is the most common type of skin cancer. Again, it's caused by ultraviolet radiation from the sun or from tanning beds, and it begins in the cells that form the base of the epidermis. Now, when we talk about basal cell and squamous cell, the primary treatment for most of these is surgical resection. So going to a dermatologist's office, having the area around the lesion numbed, and then they just extract or remove the lesion, and it goes away. Usually it doesn't grow back, it's not metastatic, it's not malignant. So for the majority of these, surgery is curative. But there are cases in which you would want some type of pharmaceutical for this as opposed to surgery. And so here are some other visual illustrations with A, B, C, D, and E of other patients that have had basal cell carcinomas on their skin. The risk factors include blonde or red hair, blue or green eyes, light skin color, and exposure to things like arsenic, coal, ionizing radiation, smoking, tanning bed use, and ultraviolet radiation. And then we have gender dermatoses. So we have inherited conditions like albinism, and what I'll talk about on the next slide, the nevoid basal cell carcinoma syndrome or Gorlin syndrome. Immunosuppression is also a problem. So recipients of organ transplants are 100 times more likely to develop cancer, skin cancer, and any type of cancer, than the general population. And this is a tribute to how effective our immune systems are typically in clearing cancers that we will never know that we would have had or may have had. Statistics for basal cell carcinoma include that Hawaii is #1 in this type of cancer. Not surprising that this is the southernmost state, and typically it's the Garden Island of Kauai. When we think about inherited mutations that would cause a basal cell carcinoma, Gorlin syndrome, it's also known as basal cell nevus syndrome. It's a rare autosomal dominant disorder. Carriers are prone to developing multiple basal cell carcinomas at an early age, with occurrence of new lesions being common throughout their lifetime. It's caused by a mutation in the patched gene of the human chromosome. I will get to a visual illustration of patched in the subsequent slide. This patched mutation plays an important role in the regulation of a hedgehog pathway, and individuals have a 5% risk of developing medulloblastoma, a pediatric malignant tumor of the cerebellum, and they're also at risk of developing rhabdomyosarcoma. Then we also have somatic mutations. So basal cell carcinoma is a situation where inherited mutations, germline mutations can leave people susceptible, but then there's also somatic spontaneous mutations that can have people with increased susceptibility as well. So here we're looking at smooth end. So the binding of sonic hedgehog to the receptor, patched, which is not visualized here, is thought to prevent the inhibition of this receptor on the surface, which is called smooth end. So this is a predicted structure of the smooth end protein. And so there are 3 identifications of activating mutations in smooth end. And so some of these are illustrated here. And so what you're looking at is the region here through the transmembrane region all the way down to this area. So right here on smooth end, we have mutations where the tryptophan protein at 535 is actually substituted with leucine, or the arginine residue at 562 is substituted for glutamine. And so these are activating somatic missense mutations. As I said previously, most of your mutations are going to be activating mutations to increase the signaling or just the activity and the function of these proteins. And so here's what it looks like putting it together. So with Gorlin syndrome, you may have had, or these patients may have, inherited mutations of patched. Patched serves to bind ligands, but the purpose of this is to inhibit the receptor smooth end, which is here. Smooth end, there are somatic mutations that can arise in smooth end. Smooth end you want inhibited because if not, smooth end will go on to signal and activate different types of transcription factors. And these transcription factors, here you see them in the nucleus of the cell, will go on to cause growth that is unregulated in the cell. However, what you also see on this slide as well is vismodegib. So vismodegib is the first in class small molecule inhibitor that was designed to inhibit smooth end. So in this way, it can inhibit either a germline mutation or a somatic mutation that can cause basal cell carcinoma. Now, as I said previously, basal cell carcinoma is curative, has very, very low malignant potential through surgical removal by a dermatologist. However, there are cases where removing the skin, perhaps on the face or other extremities, would be so disfiguring that that may not be appropriate or desirable by the patient, or it may not be something that they want to try first. And so vismodegib was approved and really targeted to that particular population. So its indication is treatment of adults with metastatic basal cell carcinoma, which is very rare, or with locally advanced basal cell carcinoma that has recurred following surgery, or those who are not candidates for surgery and who are not candidates for radiation. So if they're not candidates for surgery, again, removing the areas would be so disfiguring that it's not something the patients desire. So in this case, they could take an oral once daily administration of vismodegib, which inhibits the hedgehog signaling pathway. And so here we're looking at the clinical trial. The overall response rate was about 43% of those patients that had locally advanced basal cell carcinoma. And the rate of overall response for those that have metastatic basal cell carcinoma, which again is very, very rare, was about 30%. And so based upon that information, the drug received FDA approval. And so here is a waterfall plot looking at the change in lesion diameter of those with metastatic basal cell carcinoma. We're looking at the 30% dotted line because this is the response evaluation criteria in solid tumors, so you have to get below 30%. And so these dark bars are showing those that had a partial response to vismodegib. Now, if we look at B, we're looking at locally advanced basal cell carcinoma. Obviously, we have many more cases than what we have for metastatic, which is rare. And we're looking at those that have had a change in lesion diameter. Again, it has to be more than 30%. And so this is a really beautiful waterfall plot showing that a large percentage of these patients did have a response, or at least stable disease response to vismodegib. And so here's some sort of graphic pictures looking at, these are in the New England Journal of Medicine, looking at the baseline week 8 and week 20 after oral administration with vismodegib. Here's a gentleman on the back of the ear and then on the back of the neck. Now, I know that this picture looks pixelated. That's how it looked in the New England Journal of Medicine. For what reason, I'm not entirely sure. But again, showing the repair of the skin from vismodegib. And this may sort of give you a sense somewhat of why surgical intervention of a lesion this big may not be as appropriate as a first try versus an oral drug that may have some efficacy. So again, this is a case where either inherited genetics or somatic mutation genetics lead to basal cell carcinoma, and then we have a targeted therapeutic to go after that. So the next example I'm going to give before we're going to watch a video is chronic myeloid leukemia, so BCR-ABL. And this comes about by formation of Philadelphia chromosome, where we have a piece of chromosome 9 break off and exchange with a piece of chromosome 22. And through this, we have a newly formed chromosome that makes a really nasty little enzyme protein that causes excessive proliferation in the cells, and this forms leukemia. And so now what I want to do is watch a 14-minute video about this. And when you're listening to this video, what I want you to pay attention to is what drug are they talking about, what type of cancer, and this will also be on your quiz, who's the little boy, what's the name of the fund, the cancer fund that they're going to create to raise money for this. So what's the drug, what's the cancer, and what's the name of the cancer fund?
Name of the boy, name of the cancer fund, drug.
How many have cancer in the U.S. today? No man knows. What causes this is one of the riddles men puzzle over in their laboratories for a lifetime.
In the 1930s, a diagnosis of cancer was always grim.
We had surgery, and surgeons were perfecting their technique, trying to take out more and more tumor. And then you had radiotherapy, but radiotherapy was very crude in the 1930s.
And with cancers like leukemia that are disseminated in the blood, there was no cure.
Because you couldn't give radiation to the whole body without killing the patient, and you couldn't obviously do surgery with the whole body involved.
In a basement lab at Children's Hospital in Boston, a pathologist named Sidney Farber was trying something new. He was looking for a way to kill childhood leukemia with chemicals.
Sidney Farber was not well loved in Boston. He was this autocratic, stern kind of person which tends to put people off. So nobody wanted to give him facilities to do what he wanted to do because they thought he was crazy.
In 1946, a colleague of Farber's, a chemist named Yellapragada Subbarao, had shown that folic acid could cure a certain kind of anemia.
Dr. Farber thought, well, maybe this could be effective in acute leukemia, since they were both blood disorders.
He obtained some folic acid from Dr. Subbarao and injected it into children with acute lymphoblastic leukemia, an always fatal disease.
He was a pathologist. He was not trained to take care of people, let alone little people. So you can imagine the attitude to what he was doing.
The experiment backfired. The folates only stimulated the cancer cells.
Well, that seems like a disaster, and today, of course, it would be a disaster. But, of course, that gave him another idea.
Naturally, he said, well, if folates increase the growth, why not try antifolates?
This time, Farber got an antifolate, a drug called aminopterin, and gave it to 16 children with ALL.
And much to his surprise this time, instead of stimulating the leukemia, it massively destroyed the leukemia.
It was unprecedented that you could see a remission from giving the chemical to a patient.
It was written up in the New England Journal of Medicine, where it stirred a small controversy because the patients all relapsed.
There were lots of papers written by very famous hematologists who said, you shouldn't do this because, you may think it's really a terrific thing, but just still, patients are all dying, so it doesn't mean anything. But it meant something to people who were thinking, if we're going to make progress in cancer, we have to do something about these cells that are circulating around the bloodstream.
Tonight we take you to a little fellow named Jimmy. Jimmy is suffering from cancer.
Cancer needed a poster child.
Valley Moon with his favorite team, the Boston Braves.
Hi, Jimmy. My name is Bill Macy.
In 1948, Farber helped launch the Jimmy Fund, which would raise millions for the cause.
Honey, I'm right there. You're not with me.
Dollars poured in and went to new cancer research centers and new cancer drugs, like methotrexate, a relative of aminopterin that was easier to produce. The drugs were all highly toxic, and they worked in a crude way, killing healthy cells along with the cancer cells. Sometimes patients died from the side effects.
We didn't know how to use them. We didn't know which patient to use them in.
In Memphis, Tennessee, at a newly opened children's research hospital, a team of clinicians were studying how to use chemotherapy drugs more effectively.
The hospital was opened, And Dr. Pinkel and a few early colleagues got together and systematically thought about how can we develop a protocol that might address all the problems seen in the 50s and really try to produce curative therapy.
They tried longer chemotherapy treatments in different combinations. They added cranial radiation. They gave the methotrexate directly into the spinal column. And within 10 years, they were curing half of all cases of ALL. It was progress, but what about the other half? What was different about these children and their cancers? In the 1970s, scientists would find out as they began to unlock the mystery of the cancer cells.
And we had deciphered these groups called T-cell leukemia, B-cell leukemia, or B progenitor cell leukemia. They were entirely different diseases. We've been grouping them and treating them all the same. They didn't respond all the same.
The field of cancer genetics would continue to evolve over the next 30 years, revealing hundreds of variations in almost every kind of cancer. 2 boys in Phoenix, Arizona illustrate the importance of these variations. Adam O'Connor was diagnosed with a leukemia called pre-B-cell ALL when he was 4 years old. He was treated with the standard methotrexate-based regimen. It worked.
I've been cancer-free for 11 years. I do triathlons. It's just an amazing thing that I could beat a disease like that and feel completely normal.
So did your Christmas presents come yet?
Haziel Olmeda has the same pre-B-cell ALL and got the same methotrexate-based regimen. But after 3 years, his cancer came back. Cancer genetics revealed why.
When we looked back at Haziel's leukemia to try to sort out why was it his leukemia that came back so fast and so widespread, it was determined that he had a chromosome abnormality that actually now is considered a very poor prognostic factor.
ALL, like most cancers, is the result of several chromosomal abnormalities. An adult cancer called CML, for chronic myeloid leukemia, has just one abnormality, the Philadelphia chromosome.
The abnormality was due to a translocation from 2 genes. One piece of the chromosome broke off, went to another one, and when the 2 joined, it made a new gene. And it's that gene that's driving the cell division. Now it's just saying go, 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 until the patient dies of leukemia.
Every single patient has the same oncogenic abnormality, the Philadelphia chromosome, and most other cancers are far more heterogeneous.
At his research lab in Portland, Oregon, Dr. Brian Drucker was working on a way to target just this one mutation.
If cancer is sort of like a light bulb being stuck on, chemotherapy was, let's just take a baseball bat and knock out the light. And I looked at that and said, we've got to figure out why that light bulb's stuck on. And if we can figure out why it's stuck on, then we can shut it down and we'll leave everything else intact.
Was it that we used to dream of when I started in the field that you could actually have this kind of specificity?
A lot of people say, well, we tried that, we've thought about it, it's never going to work. Just get a bigger baseball bat.
In 1995, Judy Orem learned that she had CML and was told that she had 3 to 5 years to live. She was given the standard therapy, a drug called interferon.
The interferon really didn't do much for me. I was on it for 3 years. The best I got was down to 60% Philadelphia chromosome, which was not very good.
Dr. Drucker was testing a class of drugs that would target just the Philadelphia chromosome. He tried one called imatinib, also known as Gleevec.
We'd get patients to donate some of their leukemia cells, and we set them up in some assays with the drug, and we actually found that their leukemia cells didn't grow out in our cultures, but their normal cells did. And so it was absolutely clear that we were killing leukemia cells and not harming normal cells in cell lines, animals, and in patient samples. And that gave me great confidence that we needed to move this drug into people and see if it would work.
I had a friend who called me and said, Judy, they announced on the radio, and it was in the newspaper, that the Leukemia and Lymphoma Society had given Dr. Drucker a translational grant to take a study from, the Petri dish to get ready for human trials on CML. And I think you should get your name in there.
She did. And when the first clinical trial began in 1998, she was on it as patient number 9.
I started feeling better. I got my appetite back, my sense of smell. I put on weight.
Within 3 months, the imatinib had nearly eradicated her CML with no side effects.
They were able to actually get rid of the Philadelphia chromosome. On the interferon, I got down to 60% Philadelphia chromosome. On this, I got down to 5%.
Judy was one of the people that I remember, always referred to when people say, when did you know your drug worked?
Word spread quickly in the CML community.
Patients began to band together and realize that as a rare disease, they could actually help one another navigate through the channels, get their doctors to refer them, get themselves referred, and share information about the disease when nobody had information before.
People were soon lining up for the phase 2 trial with this miracle drug, but there was a problem.
Novartis said, we're not sure the drug is going to make enough money for us. If it's going to really hit enough people, we might stop. Well, all of us who are doing well are just panicked.
Patients caught wind of that and started to lobby the drug company for access to clinical trials.
They're kind of in a spot. Do we stop something that's working for people?
And the drug company realized they needed to ramp up production. They needed to get into phase 2 quickly.
Finally, the phase 2 trial went forward with great success. Results were reported in the New England Journal of Medicine in April 2001.
It was one of the paradigm-changing publications because it is the first proof of principle of targeted therapy.
Just 1 month later, imatinib was approved for human use by the FDA. For this one cancer, at least, it was the holy grail that scientists had been looking for since the days of Sidney Farber.
Any problems, any symptoms, any...
The last results you probably saw.
Yeah, no, everything was perfectly stable. There's absolutely no question that the work I did was built on the shoulders of giants. 50 years after Sidney Farber's work, we have a huge understanding of the genetic basis of cancer and even some of the true biochemical and metabolic differences between a cancer cell and a normal cell. And all those are becoming amenable to targeting.
It's a promising time to be an oncologist.
So you get a spinal tap and then you'll get your chemo for 5 days. There's been incredible progress over the last 4 decades. 40 years ago, it was a death sentence. And barely any children would survive their acute lymphoblastic leukemia. Now, we are curing leukemia with a cure rate of almost 95%.
Haziel's case is a tough one. While some children with ALL have the Philadelphia chromosome, now a druggable target, he has an abnormality which has not yet been targeted, and so his doctor relies on larger doses of standard chemotherapy.
Over 24 hours in a big yellow bag. When Haziel relapsed, we knew that it was an aggressive type of leukemia, and so at that point we decided that in order to give him his best chance of cure, we would perform a bone marrow transplant. So we will use his 10-year-old brother as his matched-twin sibling. So we're hoping that these donor cells are going to work and cure his leukemia, right?
Yeah.
Yeah, I think they will. I have a good feeling
I
about
do
it.
too, because he had the same numbers on everything.
Forget it.
As advances in research and therapy continue, the hope is that all cancers will one day become, if not curable, then chronic and manageable diseases.
Now we have lots of patients who've been treated and are cured. And I think as we go in the future, you're going to see more and more patients followed by the primary care physician. And I think it's a good thing.
See you soon, okay? Thank you. Bye, sweetie.
All right, and to close out class today, I'm going to go ahead and open up the quiz. And there's the code. PGX quiz, and so P and G are capitalized, and Q is capitalized as well. So there's 5 questions. Please work independently on this, and that is all we are going to do today. So thank you for your attention, and we will meet again next week, next Tuesday. Sorry to interrupt. The quiz, even though you have to work independently, it's open notes, open lecture slides, open internet, so anything.